Hello everyone, and a warm welcome to this webinar on post-authorization, stroke approval, vaccine impact and safety assessment. This webinar is part of a series of planned webinars with the goal of providing information on available career options in the field of vaccinology. My name is Clive Nyaribo, Assistant Research Officer at KEMRI-Wellcome Trust Research Program, providing support to the Vaccine Workforce Development Program. Together with my colleagues, Professor George Warimwe, Miriam Munene, and Ravenda Nafura, welcome you to this session. Before we get started, a few housekeeping matters. Kindly take note that this webinar is being recorded. Kindly feel free to use the chat option to share your questions during the presentation, and we'll address them during the Q&A session. We'll have a few open slots for people to directly ask questions to the presenters. If your internet is stable, you can raise your hand using the available icon. As I mentioned, these are series of planned webinars with the goal of providing information on available career options in the field of vaccinology. This is being run under the KEMRI-Wellcome Trust Research Program, which is a well-known health research unit of excellence based in Kilifi and Nairobi in Kenya, as well as Mbare in Uganda. Over the years, we have excelled in the use of novel ideas and collaborations to achieve better health for Africa, while also developing African scientific leaders. Our vision of the program is to undertake cutting-edge and novel research relevant to national, regional, and global needs. It's under this program that we have the Vaccinology Workforce Development Program that aims to expand the technical know-how and capability for sustainable end-to-end vaccine research and development in Africa through training and knowledge exchange activities in the vaccine ecosystem. This involves areas such as target product providing, research and discovery, preclinical and clinical studies, biomanufacturing, regulatory affairs, and deployment. The workforce development is through three channels. One, there is internships at vaccine manufacturing institutions that aims at establishing a mentorship scheme that brings interns with the senior vaccinologists and healthy market systems and engagement with academics globally to share and strengthen experiences in vaccine research and development and manufacture and enhance career development. Two, there is a full funded master level course in vaccinology where applicants are selected based on their direct involvement in vaccine research and their professional excellence and academic achievements. And three, webinars like this one to hire career scientists, graduate and undergraduate university students in Africa to provide information on possible career options for university students for informed career decision making. This program is in alignment with the Africa Union's platform for harmonized African health products manufacturing, ambition to increase local vaccine production to meet 60% of Africa's routine immunization needs by 2040, and strengthen the capability for vaccine research, discovery, and manufacture in Africa. And this webinar series is part of this engagement. Today, we are glad to have Eunice Kagucia who will be discussing post-authorization, stroke approval, vaccine impacts, and safety assessment. Eunice Kagucia is an epidemiologist with a primary interest in using epidemiologic methods to generate evidence to inform health policy. Her research work includes post-authorization vaccine safety surveillance, vaccine impact and effectiveness evaluation, and self-surveillance. Eunice joined the Department of Epidemiology and Demography at the KEMRI-Wellcome Trust Research Program as a mid-career research fellow in 2019. Prior to joining KWTRP, she held various staff and faculty positions at the International Vaccine Access Center and at the Center for Immunization Research within the Johns Hopkins Burbank School of Public Health in Baltimore, Maryland. There she worked on several vaccine-related research studies, including vaccine impact studies and clinical vaccine trials. Eunice received her master's and PhD degrees in international health from the Johns Hopkins Burbank School of Public Health. Over to you, Eunice.
Thank you, Clive, for that presentation. And thanks everyone for joining this webinar. I'm going to turn off my video as I present, and then I will turn it back on for questions. As Clive mentioned, I'm going to be talking about post-approval evaluation of vaccines. I've shortened the title a little, but it's going to cover the areas that were covered in the title that was circulated. So in terms of what I will cover, I will begin by giving some background on post-approval vaccine evaluations, a little bit about why we would conduct them, and then I'll jump into some examples of post-approval vaccine studies that have been conducted at the KEMRI-Wellcome Trust Research Program. And then I'll give my thoughts about future priorities and opportunities in this area. Related to my edit of the title, I'm going to talk a little bit about terminology. So if you look out in the literature and out in the world, you'll see that there are various terms that are used for these studies. So sometimes they're called post-approval studies, post-licensure, post-marketing, or post-authorization. So this really reflects different phases of approval and authorization by medicine agencies. So post-approval really talks about the period after approval, and typically when a product is approved, it is licensed and then it is marketed. So post-approval, post-licensure, and post-marketing can somewhat be used synonymously. Post-authorization refers to vaccines that have received emergency use authorization. For example, during a public health emergency, I think we're all familiar with the case of COVID, where most of those vaccines were used under emergency use authorization. And so technically you'd refer to those studies as post-authorization studies rather than post-approval, post-licensure, or post-marketing. So for most of this presentation, I have stuck to post-approval, but when I say that, please consider that it includes licensure, marketing, and in some cases, authorization. So I'll begin with an overview of the vaccine development process. I imagine that people may have seen this figure perhaps throughout their career or through other presentations during this series. Typically, you'll begin with your preclinical studies as shown in this graphic here. And then you'd progress to your clinical trials, phase 1, phase 2, phase 3. And just as a reminder, for phase 1, you usually have relatively few volunteers, 20 to 100. They're typically healthy. So in some cases, this will not even be the target age for the vaccination. This is just really a study to look at the safety and to some extent the preliminary immunogenicity of the vaccine that's being studied. And then the trials will move on to phase 2, where you have hundreds of participants, usually 100 to 300. You look at expanded safety questions, and you also take a deeper dive into immunogenicity. And then you move on to phase 3, where you have thousands of individuals. You're looking at expanded safety. And importantly, you're also looking at efficacy. So looking at how well the vaccine works within a clinical trial setting. Typically for phase 2 and phase 3, you might find that there are different stages. You'll find there's a phase 2A, phase 2B, phase 3A, phase 3B, and usually those are just progressions. So once a product is done with that clinical trials phase, there will be an application for licensing. And then once the licensing is complete, then you'll go into your large-scale production and distribution, and that takes about 15 years. So this is the typical presentation of the vaccine development process, and this is a traditional approach. So a phase that is usually not talked about a lot is phase 4, and so those are the post-approval studies. Here in this figure, they refer to it as post-market surveillance. We talked about terminology a little bit ahead, and so you can think of this as synonymous with post-approval. So this will happen after review and approval, and it will include thousands to millions of individuals. And this is really about real-world safety, effectiveness, and/or impact. So why would we conduct post-approval studies? So this may be done if there was a safety signal during clinical trials, for example. So this is one instance in which it would be important to do post-authorization or post-approval studies. Here we have a nice example of the RTSS malaria vaccine. So in this publication, the authors talk about what they observed during the clinical trials. So they saw that there was an increased number of clinically suspected meningitis cases and cerebral malaria in children who received the vaccine. And all-cause mortality was also higher among vaccinated girls compared to non-vaccinated girls. So this product was licensed by the European Medicines Agency. However, the Strategic Advisory Group of Experts on Immunization, or SAGE, as well as the Malaria Policy Advisory Group, recommended further evaluation of vaccine safety in real-world settings before it could be widely deployed. And so this study was undertaken in Ghana, Kenya, and Malawi. There are probably people who are familiar with it, perhaps others who were involved in it. And they concluded that there was no evidence of vaccination being associated with an increased risk of meningitis, cerebral malaria, or mortality. And there were no new safety risks identified. So this is an example of why a post-approval study may be important to investigate a safety signal that emerged during clinical trials. The benefit of these post-approval studies is that you're able to potentially include a larger number of participants than can be included in phase 3 clinical trials, and that can help with investigation of events that occur rarely and so may not be captured within your sample size for clinical trials. So another example of why one may want to conduct a post-approval post-approval study is when there's a safety signal from passive surveillance. So when I say passive surveillance, what do I mean? Usually you will have an agency or an entity that is tasked with pharmacovigilance at the national level. So I've provided some examples here. So in the US, for example, the FDA and the CDC jointly conduct passive surveillance for vaccine events following immunization, and that is called the Vaccine Adverse Event Reporting System, or VAERS. In Kenya, we have the Pharmacy and Poisons Board within the Ministry of Health. They're tasked with pharmacovigilance. And what these entities do is they will set up a system whereby healthcare providers, the general public can submit reports of events that occur following immunization. And then based on those events, they will conduct some investigations to identify whether there might be a safety signal that warrants further investigation. And that further investigation would occur through post-approval studies. So to place this in more context, I have an example here from the US on rotavirus vaccine. So this is an old rotavirus vaccine that was distributed in the US beginning in 1998. It was a tetravalent vaccine. I believe the trade name was RotaShield. So between October 1998 and May 1999, the Vaccine Adverse Events Reporting System, or VAERS, received 9 reports of interception, and that is a condition where the intestines telescope. It's a serious condition. So they received 9 reports of interception among infants who were given this tetravalent rotavirus vaccine, compared with only 4 reports overall in the 7 years before the vaccine was introduced. So when this data were received and evaluated, the FDA and CDC, who jointly ran the VAERS, temporarily suspended the vaccine and initiated a case control investigation to evaluate the potential signal. So this is an example of a phase 4 study using a case control design. So when they did this analysis, they found that there was a strong association between this vaccine and interception. This was a really high odds ratio of something like 27. And so they concluded that rotavirus vaccines with an improved safety profile are urgently needed. And we currently have I guess, new generation rotavirus vaccines, and interception is also always one of the events that is evaluated during clinical trials and also post-approval. Another reason why it's important to conduct phase 4 studies is to study safety in under or unrepresented populations. So one example of such a population is pregnant persons. So pregnant persons are typically excluded from clinical trials, and that is because of safety concerns. There are concerns about what an investigational product, what effects it might have on the fetus. There also are perhaps some scientific concerns about whether perhaps the physiology during pregnancy might impact responses to the vaccine, but predominantly it's ethical concerns about the effect of a product on the fetus. On the other hand, there are concerns about not representing pregnant persons in clinical trials, because that means that when many products are licensed, they do not have safety data among pregnant persons, and that creates a dilemma on whether the product can be recommended for use in pregnant persons. So a good example and a recent one that came up in this respect is COVID-19 vaccine safety among pregnant persons. They were not included in clinical trials, at least in the initial phase for COVID-19 vaccines. However, in the context of a pandemic, clinicians have to balance the protection of the mother and fetus against what has been recommended. And in addition, there are people who might receive the vaccine not knowing that they're pregnant. Furthermore, there are pregnant persons who may choose to receive the vaccine regardless of the recommendation. So this study was conducted by Shimabukuro and colleagues. And what they did is they looked at data among pregnant persons who received COVID vaccine, and they looked at safety, and they did not find any safety signals, but recommended continued surveillance for safety events among this population. Changing gears a little bit, moving away from safety, it's also important to look at the real-world effectiveness or impact of vaccines. A little side note here about terminology when we talk about impact versus effectiveness. So when we talk about impact studies, these are studies that are done at the population level, and you're looking at what the population effect of vaccination programs is. So at this point, you're not looking at individuals' vaccination status. This is commonly done, for example, using cluster randomized trials where there's a phased introduction or a cluster that has not received the vaccine, or using before and after studies. Effectiveness studies, on the other hand, look to estimate what the effect of a vaccine is among vaccinated individuals. So here there is ascertainment of vaccination status among individuals. This can be conducted using cohort studies where you enroll individuals, and then you, regardless of whether they are vaccinated or not, you ascertain what their exposure status is once you've enrolled them, and then you follow them out to see whether they have the outcome. And you can nest some various designs within cohort studies, or you can conduct case control designs where you look for people who have the outcome, and then you ascertain whether they've been exposed to the vaccine or not, and generate your effectiveness estimate. And there are various options for case control study designs. So just a note, when we talk about impact, we're talking about the population level effect of the vaccination program. Effectiveness, you're looking to estimate some measure, some effect measure for vaccinated individuals. So here we have an example of effectiveness study of rotavirus vaccination. This is a bit different. It's a systematic review, but they explain quite well why it's important to do this. So after 10 years of post-licensure data across various countries, they wanted to assess the effectiveness of rotavirus vaccines in routine programmatic use, because there are different settings that are introduced, settings with low child mortality, high child mortality. They also wanted to look at issues that were not addressed in clinical trials. So that includes the effectiveness of incomplete vaccination series, protection beyond the first year of life, and effectiveness by disease severity. So phase 4 studies or post-approval studies can also help you to look at objectives that were either not addressed or not fully addressed in clinical trials. So here they were looking at the new generation vaccines. So there's a monovalent and there's also a pentavalent vaccine. When they looked at it, they were able to generate various vaccine effectiveness estimates stratified by settings with low, medium, and high child mortality. They were also able to look at protection from a partial vaccination series, and also what protection looked like beyond infancy. You can also use phase 4 studies to look at the effectiveness and impact of vaccines among underrepresented populations. Here there's a nice example from the US on RSV vaccine. So this is a respiratory syncytial virus vaccine. This has been licensed for use among adults aged 60 years and older. However, here the authors note that the clinical trials were not sufficiently powered to assess efficacy against hospitalization associated with RSV infection. The studies did not include immunocompromised patients, and they underrepresented older individuals, so adults aged 75 years and older, who are at higher risk for RSV disease. So this post-approval study looked at RSV vaccine effectiveness against RSV hospitalization among adults 60 years and older. So here they're able to show that vaccination was associated with a reduced likelihood of hospitalization. That's something that wasn't fully evaluated during the clinical trials. And they also generate data for older individuals in terms of vaccine effectiveness. And so they also show that among individuals with immunocompromising conditions, the vaccine is effective as well. So this is not an exhaustive list of why we may want to conduct post-approval studies, just to sort of give an overview of why they are important. So I'll now take a deep dive into some examples of studies that we have conducted at the KEMRI-Wellcome Trust Research Program on post-authorization safety to sort of bring this idea a bit more to life. So I'll begin with post-authorization safety surveillance for COVID-19 vaccines. Similar to many settings, the COVID-19 vaccination program rollout in Kenya was staggered. It began with the adult population, initially among frontline workers in March 2021. This was a bit later than when COVID-19 vaccination programs were rolled out in high-income settings, but similar to many other settings in sub-Saharan Africa. It was then rolled out to the teenage population in November 2021, and a booster dose was introduced in December 2021. The products within the Kenya COVID-19 vaccination program included the Oxford AstraZeneca product, Pfizer, Johnson & Johnson, Moderna, Sinopharm, and there was very limited use of Sputnik V. So when these vaccines were rolled out, there was an emerging risk of adverse events of special interest, and this had been ascertained from passive and active vaccine safety monitoring in high-income settings. So I'll just take a little bit of a detour to talk a little bit about adverse events of special interest. These are important for post-authorization safety monitoring, as well as clinical trials. These are events that are serious. Typically, they occur rarely, but they're important to assess during the post-authorization period. And these are defined as events that are of scientific and medical interest or concern to the product, And there's this group that is called the Safety Platform for Emergency Vaccines, or SPEAK, that is funded by CEPI. And they have listed some criteria for identifying or listing which conditions they prioritize for AESI. So these would be conditions that have a known association with immunization in general. So for example, here you'll see anaphylaxis, that's common to all vaccines, or a known association to a specific vaccine platform. We now know from the COVID experience that for adeno-vectored vaccines, there's a theoretical and shown risk for some products for thrombocytopenic thrombosis syndrome, or that would occur during wild-type disease. So if there's a condition that would occur due to wild-type disease, you might want to assess whether it might also occur in the context of vaccination. So for example, this is a list for COVID vaccines, and so they show here some conditions that are specific to disease and that you want to monitor for in the context of vaccination, or theoretical conditions based on preclinical studies. So this is not an exhaustive list. I've listed here the link to the SPEAK website, where you can go into various vaccines and adverse events of special interest, as well as standard case definitions. And these are important to inform the focus of post-authorization studies, where in addition to reactogenicity events, which are like your typical injection site reactions and other systemic reactions, you also may want to look at specific events, serious events, termed as adverse events of special interest. So back to the study in Kenya, why did we think it would be important to conduct this study? We thought that it would be important to understand the safety profile of COVID vaccines within an alternative epidemiologic context to what was available at the time, which was predominantly data from high-income settings. We thought that the epidemiologic context in Kenya was different from those high-income settings in several respects. First, we knew from serosurveillance studies that there was a high cumulative incidence of SARS-CoV-2 infection. So when the vaccines were introduced, there was a substantial proportion of the general population that had been exposed to COVID, compared to high-income settings where when the vaccine was introduced, there had not been as much spread of COVID. I've also talked about the COVID-19 vaccination product, which included multiple products. And with those multiple products, you have various schedules, and you also have product mixing. And then there's also a double burden of communicable and non-communicable disease, and potentially some theoretical questions about how that might interact with COVID-19 vaccination. So we undertook active vaccine safety surveillance using a cohort event monitoring, or CEM approach. This is really just a prospective observational cohort. So post-approval studies are typically observational studies. It was conducted at 7 health facilities within Kilifi County that are shown in the figure here. And there's more information in a preprint that we have authored, with the first author being Don Bryan, who I believe is on the webinar. In terms of procedures, what we did is we enrolled individuals who had received COVID vaccination after they were vaccinated within the routine system. We obtained informed consent, and there were 2 subsets. So there was a reactogenicity subset that was followed up daily for 7 days after vaccination, and they were followed for solicited systemic reactogenicity events, which were fever, headache, chills, fatigue, joint pains, muscle aches, malaise, and nausea. And then they were followed weekly over 13 weeks. And there was also a non-reactogenicity subset who were not followed for systemic reactogenicity events, but were followed up weekly for 13 weeks. And this was for other post-vaccination events, including hospitalization. it's important to note that we collaborated with the National Vaccines and Immunization Program as well as the Pharmacy Poisons Board on this study, and we submitted all the events that we identified from this active surveillance into the passive surveillance system, which is the Pharmacovigilance Electronic Reporting System, or PVERS. So we enrolled 2,440 participants. 1,000 went into the reactogenicity subset, and this study was conducted between September 2022 and June 2023. With respect to age, most of the participants were young. More than half were aged 17 to 39 years. Most were female, and among the female participants, 535, which represented 28%, were pregnant. So this is just to summarize the vaccine product and dose. I don't expect you to look through all of this, but just to note that there were doses represented from the first dose to second dose and booster doses. There also was no administration of the Oxford AstraZeneca vaccine in this cohort, and that was because of the timing during which the study was conducted and what products were available. With respect to reactogenicity events, there were 595 participants who experienced one or more systemic reactogenicity event. On the left here, there's some figures showing the proportion of participants who experienced fever, headache, and fatigue. Just as an example, there were also data for the other systemic reactogenicity events that I mentioned. And what you will observe is that after 3 days after vaccination and later, the proportion of individuals with these events was lower than those who reported, generally lower than those who reported events in the 3 days before vaccination. So here, day 0 refers to the proportion of individuals who had experienced that event within the 3 days before vaccination. So there was a bit of a spike after vaccination, but this trended downwards at 3 days or later after vaccination. In terms of severity, which is shown on the right panel, you'll see that the proportion of individuals with severe systemic reactogenicity events was relatively small. We looked at predictors of reactogenicity events using logistic regression, and those regression models were adjusted for age, sex, dose, vaccine brand, and comorbidities. And we found that female sex was a predictor of reporting systemic reactogenicity events, but there was not much difference in the odds of reporting systemic reactogenicity events among pregnant and non-pregnant persons. And then with respect to brand, Johnson & Johnson and Moderna recipients had higher odds of reporting systemic reactogenicity events compared to individuals who received Pfizer vaccine. We also looked at non-reactogenicity events, as I mentioned. There were 164 hospitalizations. 133 of those were deliveries at term. These were just regular deliveries, but when you're looking at adverse events, it really is any event that occurs after vaccination. 9% of the hospitalizations were due to pregnancy complications. This represented 3% of pregnant participants, and against a background prevalence of 3 to 49%, this did not seem to indicate a higher risk of pregnancy complications among vaccinees. There are other medical conditions, 14 of them. 4 of those occurred within 42 days of vaccination. So typically when you're doing your post-approval studies for safety, you want to define a window within which you think it is biologically plausible for events to occur. So in this case, we used 42 days, sometimes 30 days are used. And that definition of that window can help with some analysis. So for example, if you're doing a self-controlled case series, you will have a period that you define as a risk window, and then you have a non-risk window, and then you compare the frequency of events then. So here we are talking about 42 days. So of those other medical conditions occurred within 42 days of vaccination. I'll talk a little bit about them. And then there are individuals who are hospitalized for elective surgery. So once again, any event occurring after vaccination is an adverse event, even if it is clearly not related to vaccination. There were also 6 non-reactogenicity events among individuals who are not hospitalized, and 5 of those 6 occurred within 42 days of vaccination. So you might be wondering what those events were. There were 9 in total that were non-reactogenicity events that occurred within 42 days of vaccination. Some hospitalized, some not. They're listed here. A limitation of this evaluation was that these events were not assessed against standard adverse events of special interest case definitions. So they were not listed to any of those AESIs or linked to any of those AESIs that I had shown earlier on when describing what AESIs are. We also had a small sample size. You'll remember that we enrolled 2,440 individuals. We had aimed to enroll 10,000, but did not reach that sample size because of various constraints. One was the funder timelines, but as well, the study started relatively late, and at that point, COVID vaccine uptake had sort of slowed down a bit. So we did have a small sample size. And what that means is that we have really wide confidence intervals for events. So for example, if you were to look at one of these events and say, this looks like it's consistent with an AESI, and it's one event, the 95% confidence interval for the incidence rate of that event would be 10 to 2,000 events per 100,000 person years. So that is not sufficient to rule out the background rate if the background rate of that event is within that confidence interval. So we didn't have sufficient confidence to be able to rule out events that occur at a rate that is, for example, higher than 10 per 100,000 person years. So in summary, we found that reactogenicity events were generally non-severe and transient. They were short-lived. There was no elevated risk of adverse pregnancy outcomes. We've just talked about the insufficient sample size to evaluate the risk of other adverse events of special interest other than adverse pregnancy outcomes. But we could rule out a 2 to 3-fold increase in the risk of acute aseptic arthritis, and that's because it happens, its frequency is relatively common, so we could rule that out. We also thought that there's a need to address operational barriers so that we can conduct this post-approval safety assessments more rapidly and be able to achieve the targeted sample size so that we have evidence that is informative for policy. I just wanted to acknowledge the teams that worked on this study, as well as collaborators within the Kilifi County Department of Health, the National Vaccines and Immunization Program, the Pharmacy and Poisons Board, and this was funded by the UK FCDO. So changing gears, I'll go to a second example, and this is on the post-approval impact of pneumococcal conjugate vaccine in Kilifi, Kenya. This is a population-level study. That's the use of the word impact. So just a little bit of background on pneumococcal disease and conjugate vaccines. Pneumococcus is a bacterium that is typically carried harmlessly within the nasopharynges. However, it can infect usually sterile sites, resulting in meningitis, pneumonia, sepsis, and other unique invasive pneumococcal disease syndromes. So there are over 100 serotypes of pneumococcus. And for this reason, vaccines are typically serotype specific. It's been difficult so far to be able to fit all these serotypes into one vaccine. So usually we have vaccines that focus on serotypes that are shown to cause invasive pneumococcal disease. So those that are most likely to cause a high burden of disease. So there have been several pneumococcal conjugate vaccines licensed since the 2000s. There was a 7-valent one which covered 7 serotypes. It was discontinued. And currently we have 10 to 21 valent vaccines with many others in production. So I've highlighted the 10-valent vaccine here because that is what has been used in Kenya. So the 10-valent pneumococcal conjugate vaccine, or PCV10, manufactured by GSK, trade name Synflorix, was introduced into the Kenya National Infant Immunization Program in January 2011, excuse me. It was introduced with catch-up for infants. So children who were below the age of 1 year could receive up to 3 doses of vaccine. In Kilifi, there was also catch-up for children aged 1 to 4 years who received a maximum of 2 doses. And under routine use, it was given at 3 doses with no booster, and that was at age 6, 10, and 14 weeks. And then beginning in late 2022, there was a product switch from the GSK 10-valent product to the Serum Institute of India, or SII 10-valent product, trade name Pneumocell. So why would we want to conduct a post-licensure evaluation of the impact of 10-valent pneumococcal conjugate vaccine in Kenya? So Kenya was the first African country to introduce this product into the National Immunization Program. There had been no clinical trials of PCV10 in Africa, so there was a bit of an evidence gap there. There was also a question about herd effects. Pneumococcal conjugate vaccines are interesting in that when you vaccinate children, they, because of reduced transmission, you end up seeing an effect in older individuals, including older children and older adults, predominantly older adults. This had been seen in high-income settings who had introduced pneumococcal conjugate vaccines earlier than in Kenya. And so there's a question about whether you would see similar herd effects in Kenya, given a different epidemiological context. There was also questions about a phenomenon that had emerged called serotype replacement, whereby serotypes that were not included in the vaccine increased in courage and in some cases in disease. And so the question was, would we see that in Kenya as well, and what would the magnitude be? So we conducted a number of surveillance approaches. I'll focus on surveillance for invasive pneumococcal disease. And this was conducted at the Kilifi County Referral Hospital and included blood culture on all children. And this was done routinely with some exceptions, as well as CSF culture on children with suspected meningitis. There was also blood culture on adults with suspected invasive bacterial disease, again with CSF culture for those with suspected meningitis. The admissions were linked to the Kilifi Health Demographic and Surveillance System, or HDSS, residents, and this helps to define a population denominator that can be used to estimate incidence rates. And we conducted pneumococcal identification and serotyping according to WHO guidelines through the laboratory surveillance platform here. There was health facility and community-based vaccination coverage monitoring. This was done using a prospective health facility-based vaccination registry through 2018 and using a retrospective coverage survey in 2021. So it's important to understand what vaccination coverage is, even when you're conducting these population level assessments, because you want to have a plausible link between any effects identified with vaccination coverage And here we have some data from 2 articles published by colleagues at the program. And so you'll see that coverage within the birth cohort between vaccine introduction and 2021 was relatively high, ranging from about 84% to 93% over that surveillance period. So looking at the impact of the 10-valent GSK product, the Synflorix product, on invasive pneumococcal disease, when you look at these figures, you'll see that there's a vertical dashed line that represents the introduction of a pneumococcal conjugate vaccine. The points shown are incidence per 100,000 population, and this is stratified by children below the age of 5 years who would be within the target vaccination group, older children, and then individuals aged 15 years and older. And the different lines represent all invasive pneumococcal disease, so due to all serotypes in the black line. And then you have vaccine type invasive pneumococcal disease, so disease that is due to serotypes covered in the vaccine, as well as disease due to serotypes not in the vaccine. So if you look at these figures, just eyeballing them, you see really a dramatic decrease in the incidence of all serotype invasive pneumococcal disease in all ages. This is due to decreases in invasive pneumococcal disease due to vaccine types, that is the red line. You also see some suggestion of an increase in incidence due to non-vaccine serotypes, which are shown by the blue line. But when we take a deeper dive, we have our estimates of impact. So among children aged below 5 years, there was a 68% reduction in the incidence of invasive pneumococcal disease due to all serotypes, a dramatic reduction of 91% in the invasive disease caused by the serotypes included in the vaccine, and some non-significant increases in non-vaccine type disease incidence. So even though there has been a bit of an increase in the incidence of invasive pneumococcal disease due to non-vaccine types, this has not been sufficient to negate the reduction due to serotypes included in the vaccines. There are also significant reductions in vaccine type invasive pneumococcal disease incidence among persons aged 5 years and older. And this is evidence of herd effects in our setting, and also in all IPD among children aged 5 to 14 years of age. So I just wanted to acknowledge the study team that has been working on these studies. Many of them, before I joined the program, you'll see that the surveillance started in 1999, as well as the funders and study participants. I also wanted to just briefly mention, in case people might be interested, to look at some additional studies out of the program. So this study has been published by Ruth, Lucinda, and many other colleagues, and it is on COVID-19 vaccine effectiveness. And if people are interested, they can take a look at that. This is yet another example of post-authorization assessment, this time for COVID-19 vaccine assessment effectiveness in Kenya. So I thought I would reflect a little bit on future priorities and opportunities for post-approval evaluations. So here we have a similar figure to what I'd shown at the beginning of the talk from this publication by Florian Kramer. And in this case, the initial figure was about traditional vaccine development. This is about SARS-CoV-2 vaccine development. And what you'll notice, if you remember earlier, the pipeline was about 15 years. For COVID vaccines, it was about 10 months to 1.5 years in total. So there is an interest in being able to rapidly develop vaccines for emergency use when there's a public health emergency. So for example, CEPI has their 100-day mission to be able to roll out a vaccine in the case of a public health emergency within 100 days. So what this means is the timeline for clinical trials is condensed. And so there's a need to ensure that there's post-approval evaluations to be able to look at these questions of safety and effectiveness for vaccines that have a much more condensed production process. But I will note that, of course, this is not implying that there's a lower vaccine safety profile. These vaccines are still evaluated for safety under clinical trial conditions. It's just that this gives an opportunity to be able to assess the safety within a larger sample size and potentially within populations that were not included in the clinical trials. There's also opportunities with respect to maternal vaccines. So there are a number of maternal vaccines in the pipeline. Respiratory syncytial virus vaccine has been licensed for use in pregnancy in high-income settings, likely to be introduced within low and middle-income settings imminently. There are also maternal vaccines in development for Group B streptococcus and considerations for maternal vaccination for other conditions. So this will be an area where it's important to continue conducting those post-approval studies. Also for new infant vaccine introductions, formulations, and schedules, particularly as countries that are under Gavi support begin to transition out of Gavi support, there will be thoughts about perhaps changing the formulations of vaccines for formulations that are more affordable, thinking about different schedules. Is there a need to optimize the schedule for effectiveness, or is it possible to have reduced schedules that can still have the same level of effect? And so it will be important once more to look at safety and effectiveness or impact in the post-authorization period. And there are also new vaccines that are being introduced to help reduce child mortality. I think perhaps another area of interest that there may be for sub-Saharan Africa is utilization of healthcare databases. As countries continue to introduce national healthcare systems using digital health to capture data, and also perhaps linking to private healthcare databases. There are data that can be used for these post-approval evaluations. In high-income settings, this is typically done. It is an efficient way of conducting this studies where you have information on exposures and outcomes within healthcare databases. And it's also possible to do some observational studies that simulate randomized controlled trials, for example, target trial emulations using healthcare database, using data from healthcare databases. So that brings me to the end of my reflections. Thank you for your attention and for attending, and I'm happy to take questions.
Thank you, Eunice, for the informative presentation. We'll take questions. Can raise your hand using the icon so that you can ask the questions. Start from Ignatius. Ignatius Mungangi. Ignatius, kindly go ahead.
Can you?
Yes, we can.
Okay, my name is Ignatius. I'm just a student, and I have two naive questions to ask. The first one is, first let me comment that has been a wonderful presentation. And my first question is, what gaps remain in the coastal region health infrastructure that limit the post-authorization vaccine monitoring? And how can KEMRI-Wellcome Trust help address this? Then number two, just out of my curiosity, how can Africa strengthen its capacity for vaccine pharmacovigilance and impact monitoring without the over-reliance on external systems. Yeah.
Thank you. Yes, kindly go ahead.
Thanks, Ignatius. Those are really weighty questions. Maybe I'll begin with the second one on pharmacovigilance. I think training is important because that helps to build capacity. We have colleagues on the call, I think, who are working on a project. It's a project within my team, so I shouldn't say colleagues as if I'm not involved in it. But part of it has been looking at factors that support, so facilitators and barriers to surveillance for adverse events following immunization. So training is one of the things that has come up. There are also aspects at the organizational level. So this is infrastructure. So when these events occur, there's a need to have sufficient resources to investigate the events because that informs causality. Causality assessments are typically within the domain of the Pharmacy and Poisons Board, and that is what would help to identify whether there's a safety signal. So you also need training in pharmacovigilance, so individuals who are well equipped to be able to conduct these analysis. With respect to gaps within the coastal region, I'll say that first of all, to begin with, there is an existing national pharmacovigilance system. There have been a lot of efforts to make the general public and healthcare providers aware of this system. Perhaps there's a need for ongoing engagement around that. So there is a national pharmacovigilance system. Studies like the one that I've described, that is more active surveillance. So that is not intended to be something that is operational all the time. It's something that is activated when there's an important question, a short-lived assessment that generates information that can then be used. So the passive surveillance system is there. It's perhaps just resources to support active surveillance when that is needed. But there are various efforts that are ongoing. There is an effort to, for example, develop pregnancy registries, which can help with safety surveillance in pregnancy, so for maternal vaccines, that is. For impact evaluations, it really is just investments in being able to collect data, and some of this data can be collected routinely, but the quality needs to be really good for us to be able to use routine data for these impact and effectiveness evaluations. And so there are opportunities within the routine public health system for improved data quality that can then be leveraged for these assessments. So I think I'll stop there, but I think that's a very deep question that probably could involve a lot more discussion. But those are my thoughts off the top of my head. Thanks.
Thank you. Go to the next question. You can also use the chat and Q&A sections to post the questions. You can also use the icon. VA, kindly go ahead. Hello. VA, kindly go ahead. We have unmuted. VA, kindly go ahead. We have unmuted. VA, kindly go ahead. Go to the next person as he works on the mic. Via, the mic is unmuted. Kindly unmute the mic and go ahead. Possibly use the chat option to post your question kindly. Go to Ezekiel. Ezekiel, kindly go ahead.
Thank you. Cliff, confirm that you can hear me.
Yes, we can. Sure.
Yeah, so my name is Ezekiel. I'm a student at KEMRI, PhD, and thank you for the wonderful presentation. In my master's, I did a research about uptake of malaria vaccine in Bungoma County, and part of what I found out during the qualitative study was feedback from the CHVs and the caregivers, and part of that was what has just been presented. Of course, I was not able to report it anywhere apart from the research. I wanted to find out from Dr. Eunice what is the threshold of pulling back a vaccine which has been approved? Are there vaccines in the market which have been pulled back or recalled? Let me use the word recall. I'm a student, so I'm still learning. Recalled from the market because of a post-approval surveillance, and a threshold was reached where the vaccine was deemed not fit for scale up. Thank you.
Thanks, Ezekiel. It sounds like your research was very interesting. There are always concerns about vaccine safety, but I just wanted to emphasize once more before the vaccines go into approval, licensure, and marketing, there are clinical trials where there have been investigations on vaccine safety. There are examples, or I should say there's an example, one comes to mind, which is the rotavirus vaccine. So that was one of the earlier examples I'd shown when talking about why we want to conduct post-approval authorization. So that vaccine, RotaShield, was introduced into the US in 1998. And then, as I'd mentioned, there was this evidence of intussusception, telescoping of the intestines within less than a year. And that prompted a case control evaluation of the safety. And they found that the vaccine was associated with a risk of intussusception. So the manufacturer elected to pull that vaccine off the shelves, and companies went back to developing vaccines, and now we have vaccine products that are available. So what will happen nowadays during clinical trials for rotavirus vaccine, there will be evaluation for intussusception, and after they're licensed, there will be ongoing passive surveillance, and if needed, active surveillance for intussusception. The thinking around intussusception has changed just a little bit with respect to thinking about the risks and benefits of vaccination. So that intussusception condition is not only due to the vaccine, but you can find it due to natural rotavirus infection, for example. So there's a need to balance out that risk of intussusception with the benefits conferred by vaccination in terms of preventing rotavirus disease or reducing its severity. So there's a need to balance that. But so there is an example. So when a safety signal is identified, investigated, and there's found to be an association, the next thing that will happen is balancing, thinking about the risks and benefits. So what are the benefits that the vaccine confers? If you pull it from the market, what will be the impact of that? What is the risk of the vaccine versus its benefits? So there's always that consideration. But there is one example. If you have time, you can look it up, RotaShield. But I should also say there also needs to be a lot of careful communication to the community and the general public when something like that occurs.
Yes, I'm going to again allow VA to ask the question. Yes,
So I think
Phil.
they've posted in the chat.
Yeah. Okay. Yeah, he has actually.
Yeah. So I think my question have. Please, can you hear me?
Yes, we can. Sure.
Hello, can you hear me?
Yeah, we can. Hello, we can hear
Okay.
you.
So
Yes.
okay. So I'm from Ghana. I think I'm probably the only Ghanaian joining the meeting. I saw this when I decided to join. I think Kenya has gone quite far with regards to safety monitoring in terms of vaccine and vaccinology, and I'm looking for opportunity to advance in that area. I had wanted to find out also if there's any collaborative effort in terms of vaccine monitoring as far as the continent is concerned. Is there anything that the continent is doing in terms of vaccine monitoring or safety monitoring for vaccines? And if there are, how can I join? If there are, I remember at the beginning someone had mentioned that there were opportunities for Vaccinology. I don't find that in Ghana. How can I be a part of this? Thank you.
Yeah. Yes, can take that.
Sure. So I'll comment and then I'll also move it back to you because I think it sounded like there's a general question about the Vaccinology series.
Sure.
So for vaccine safety monitoring, a lot of it is conducted within entities embedded in government. So for example, in Ghana, I do know the Ghana FDA are the body that is responsible for national pharmacovigilance. So that includes safety monitoring for drugs, vaccines, and other biologicals. At the regional level within WHO Afro, there's also a safety monitoring mechanisms. There's AVAREF. There's also within AUDA NEPAD AU3S. So there are various bodies that are tasked with this safety surveillance. So I would say for you, I'd mention you can look into Ghana FDA AU3S within AUDA NEPAD, AVAREF within WHO Afro. The opportunities that the research that I've described has been conducted through collaborations between researchers and pharmacovigilance entities. And so that is also another approach into getting into safety monitoring for vaccines. This, of course, requires, writing up proposals and getting funding from funders to support the research end of this. Ghana does really have a strong safety monitoring program. I'd shown an example of post-approval evaluation of RTSS malaria vaccine, and that was conducted in Ghana. I know for a couple of other vaccine safety monitoring projects that I'm involved in, there are collaborators from Ghana, both from FDA and from research institutions. So there are opportunities there. Part of it would also be looking into training opportunities for the skills that would be needed either for designing studies or analyzing data. So I don't know if you had anything to add on that, Clevers, with respect to the larger vaccinology series.
Yeah, yes, actually, you basically answered the way it is that The safety monitoring of vaccines is normally a responsibility of the NRS, as the national regulatory agencies in various countries. But under the AU NEPAD, there is the regional centers for excellence, and in Ghana, actually, the University of Ghana Medical School is one of the regional center for excellence in pharmacovigilance. So there are opportunities in collaborative opportunities for vaccine safety monitoring. Then all these studies will always have collaborators. You'll find studies happening in different countries at the same, but not all the countries. You'll find maybe 2-3 countries collaborating in different safety studies. But ultimately, the responsibility lies within the NRS in vaccine safety monitoring. For maybe she can look at those regional centers of excellence, whereby even the University of Ghana, that's the medical school, is one of the excellence centers for pharmacovigilance. Yes, thank you. We go to the next question. What is Kenyan? That's from Francis Wadera. What is Kenya's capacity and by extension Africa's capacity to carry out swift adverse effects of civic interests, post-vaccines introductions? Where can you rate it, especially as we move to the space of rapid vaccine development, testing and rollout? This is from Francis Wadera.
I think there's a lot of capacity. Perhaps the challenges with respect to resources, but I'd say in terms of expertise that exists. Clive has just talked about the role of national regulatory agencies to conduct pharmacovigilance. And I'd mentioned before that Kenya PPB is the agency in Kenya that is responsible for that. PPB does initiate or has a history of initiating active surveillance studies as needed. So I'm aware of them having conducted at least one cohort event monitoring study in collaboration with others. I think perhaps there's always a need, and that is common not just to this area of research, but there's a need for more sustainable funding for these activities. I think if the funding was there, it would be feasible to be able to rapidly roll out this active vaccine safety monitoring studies as needed. And then similar to the response to Ignatius, there's also a need for training because although there is existing expertise, I don't think there are a lot of people who have training in this area. So it would be good to continue training epidemiologists, data scientists, medical officers in this area of vaccine safety monitoring so that you have more human resource capacity to conduct these evaluations.
True, training is the way to go to build the capacity in Africa. Though currently most of the effort is towards manufacturing, but we need to do more training on post-licensure. Yes. So there is time for maybe 1 or 2 questions before we close. Is Abubakar? Yes, Abubakar.
Okay, thank you very much. So this is Abubakar Zakaria from Ghana. So I'm very keen in vaccinology, and I have been monitoring programs and webinars of KEMRI, and I have been keenly interested in the programs they organize vis-a-vis vaccinology program. I want to also further inquire whether there are short courses that will broaden one's expertise as an early career scientist in vaccinology. That is one angle. And then the other has to do, please, is a plea. Can the recordings of this be made available so that at least our spare time, we can go through it just to have an in-depth understanding of what has gone through. It's just a plea. Thank you very much.
Yes, thank you, Abakari, for the questions. Maybe I'll just answer what we do as the Vaccine Workforce Development Program. Currently, we have at least 3 avenues for training. There is the webinars, and then there is the Vaccinology in Africa course. The last one was conducted in Senegal, that is in June. Then we have also apprenticeships. Currently, there is a call for apprenticeships in Egypt, where we'll take some apprentices for training in Egypt, Cairo, that is. Then for the recordings, we'll definitely have this recording on our YouTube page. That is the KEMRI-Wellcome Trust Research Program YouTube page. Thank you. Eunice, you can add to this for capacity building,
Sure.
maybe in Africa. Yeah.
Well, I was going to also suggest you could share the link in the chat.
Yes.
So that interested people can follow up on the opportunities you've mentioned. And also for VA, there's another Ghanaian. So there's also VITS Alive. I forget what the acronym stands for. So this is within the University of Witwatersrand in South Africa. They also do have some capacity building opportunities in vaccinology, specifically for this area of pharmacovigilance, post-authorization assessments. There are some certificate courses. They are paid courses, but they do have discounted funding for students from lower middle income settings. So the London School of Hygiene has a 4-part series. It's a professional certification in pharmacovigilance. There's also Utrecht, and I'm sure there are several others. There's also a program, I believe it's called E2A, specifically in this area of post-authorization assessments, use of real-world evidence, real-world data, and so on.
Yes, thank you. There is another question from Africa Region Office. Is how do you anticipate or manage the funding challenges facing upcoming vaccine trials?
I'm sorry? Okay, sorry, with respect to funding, I'm not sure I have the answer. I think this is a perpetual dilemma, and not just in this area. The obvious response to this is more government funding towards research. Clive has talked about the BioVax initiative, for example. So there is some funding towards vaccine manufacturing, but this is more within manufacturing. With respect to trials, the situation is that these are usually externally funded, but that doesn't negate a need for that. However, even though we are talking about funding, I think it's important to acknowledge that just the fact that we have a national regulatory agency, the PPB, that has a platform for passive vaccine safety surveillance that is active, that is an actual investment. I think it's for some of these ancillary activities where perhaps more funding is needed. For vaccine trials, I think even in high income settings, these are typically funded by industry. The role of government institutions usually is probably within the basic sciences component towards development of the vaccine. So I don't think it's a surprise for vaccine trials to see that they're predominantly externally funded. But perhaps for some of these post-approval assessments, it would be nice to be able to leverage some government-funded resources, such as what I was talking about in terms of having just routine data that are of high quality and can be used. So in some settings, this is possible.
Yes, there is also another question more or less related to funding from Mercy. It's more of a statement and then a question at the end. Student here, the issue of funding, I have never understood where the problem really is. Africa's high quality expertise, but since time where we have always depended on outside sources for funds. When will Africa fund itself? A very good question. And everyone will need to answer this.
I think so. We all need to reflect on that.
We don't have another question or another hand raised. Yes, because we can close it up here, and then you'll give your remarks, last remarks for today. We appreciate for the presentation. Kindly give your remarks.
Thank you very much for attending and for the engagement and the really great questions. And thank you also for those who have provided some feedback in the chat. This is an interesting area. We do continue to look for opportunities to conduct this work, even though there are only limited opportunities. We do have some team members who've joined the program to work on this area of post-authorization safety surveillance. So whenever we have opportunities, we do our public and competitive recruitment. So perhaps we should throw that out also as an opportunity when they're available. So they're not always available. I hope that this has been of interest to some of you and that you may consider a career in post-authorization research evaluation. This is possible with some training in epidemiology and some of the other aspects that we've talked about in terms of training. So thank you. And again, wishing you a good rest of the day and week.
Yes, thank you, Eunice, and thank you very much to everyone in this webinar. We would like to hear about your experiences and what else you would like us to discuss in upcoming forums. Before we close, we kindly request that you take a few minutes to respond to the post-webinar survey posted in the chat. There is a link for that on the chat. Have a nice afternoon and looking forward to more engagement with everyone. Thank you.